دكتور حنا مخامرة، الدكتور أيمن قيس البلبيسي، قيس، الدكتور زاهر الكسيح، الدكتور سامر غانم فلسطين، الدكتور وائل القشقري موجود؟ طيب أنا بدي أسلم الواقع، مش الكو تشيرمان، راح يكون التشيرمان الدكتور حنا. احنا في عندنا حوالي تأخير 10 دقائق. الدكتور أحمد مجدي، تقدر تعمل you can do it 10 minutes ولا 15 minutes؟ 15 minutes keynotes. If you can do it less, if you cannot, it's okay.
Okay. With no further delay, our session is about bifurcation lesions. We have a keynote lecture by our colleague, the chairperson of the Egyptian Interventional Working Group, Dr. Ahmed Magdy, titled How to Optimize Bifurcation Interventions. تفضل دكتورنا.
Okay, thank you very much for the invitation, and this session is joined with the SKY, so I am happy to represent the SKY and Egypt at the same time. So this is the European Bifurcation Club. We are with them since many years, and they are progressing, and every time we think that we stopped discovering anything new about bifurcation, but still there is always something new. This is the Ischemia Club, which represents our faculty in these. So what is important related to the left main bifurcation is the clinical relevance of the side branch, the classification strategy, wiring the bifurcation lesions, pre-dilatation, adequate lesion preparation, main vessel stenting, side branch treatments, optimization, two stents, strategies, and intravascular imaging. Each one of them needs one lecture. What had developed is the different platforms of the stents, different designs, more appropriate strat thickness and cell opening, more detailed data regarding the bench testing, which is very important now to understand a lot of things, more use of imaging, more effective devices for the calcified lesions, improvement of the basic strategies, and criteria to define which is complex and which is simple, and more clinical data. These are the consensus by European Bifurcation Club over the years. Last one was 2 years ago. And so left main remains a challenge for intervention cardiologists and always high risk. Why? Because it represents almost 70% of the myocardium the left main is supplying. And if you counter for the patient comorbidities, which is very common with left main patients, heart failure, diabetes, advanced age, peripheral vascular, acute coronary syndrome, previous surgery, or complexity, which is also very common, high syntax score, multivessel disease, or the hemodynamics. Many patients present with unstable angina, low ejection fraction. And so what is the relevance of the side branch? You can imagine each of these lesion on these arteries is different than the others. The guidelines of the myocardial revascularization indicate that an artery or a branch that supplies 10% of the myocardium is important. There is something called the myocardial segmentation technique with the CT, and simply defines which are the criteria that defines the important side branch using CT, FFR to confirm which side branch is important. And they found that the side branches with lengths more than 73 are important. So the clinical relevant side branch is defined by the length of side branch, severity of stenosis, it is localized in the ostium or it is extending more than 5 and now more than 10 millimeters. This may need 2 stents. And also, if it is supplying a lot of myocardium, this makes the side branch important. So what criteria in this side branch? So the whole branch territory, the total number of branches, relative dominance, the vessel size and length. You can imagine that this side branch is 2.5 and is 80 millimeters, and the area of distribution is important. As you see, focus on how much myocardial mass, according to this criteria of mass, myocardial mass at risk. And when you lose this side branch, and then this patient developed acute infarction, although it is a side branch, and then after reopening of the side branch, remember that there was no wire, and so they were lucky to find out where the side branch, and then the infarction was aborted. The classification, appropriate approach is defined by the classification. Is it complex or not, side branch? And you can, and still the Medina classification is the one used. It's very simple. However, it doesn't give information about the lesion characteristics, the side branch size and length of the lesion, the angle, presence of calcification, tortuosity, and thrombus. What is the default strategy for bifurcation? Still the main vessel stenting, provisional, and if needed, it's recommended as a preferred technique, of course, for majority. And large side branches with significant ostial extending further in the side branch are likely to require 2 stents. And larger side branches whose access is particularly challenging and could be lost should be also secured by 2 stents. So 1 or 2 stents, according to a definition study which had been mentioned yesterday, they defined the complex lesions or complex bifurcation according to this criteria. Each one is minor, moderate to severe calcification, multiple lesions. The angle is difficult angle. Main vessel less than 2.5, thrombus containing, and the extent of the lesion more than 25. And simply they found the provision is better for the all simple lesions, and 2-stent strategy is better for all complex lesions, with exceptions, of course. Intravascular imaging is now cornerstone in left main stenting. You can see the baseline and after stent. What is the importance? Is it to do it before the stenting or after stenting? Imaging includes IVUS, OCT. For left main, FFR is not very important, but the OCT and the IVUS are very important. All these studies had shown that imaging-guided intervention left main brings much better outcome. So if you do the imaging before the intervention, it gives you idea about lesion evaluation, characteristics, lipid, fibrous, calcification, plaque burden, and so if and need for debulking, which makes your plan and your life easy, and also the main vessel, the size, the length, extent, if you need a balloon or not, all these criteria. And for the side branch, from the imaging, you can define the need for treatment, the size, the length, disease extent, all these criteria. And then during the procedure itself, it can give you an idea if there is under expansion, malapposition, deformation, edge dissection, or side branch jailing struts. And final optimization imaging also gives you an idea and gives you a definition if there is a post-dilatation, if you need further balloon, additional stenting, or else. Lesion characteristics are important, and lesion preparation, and this had developed a lot, and a key role in procedural success. Now we have cutting balloons, angioscalp, shock wave, rota, orbital rota, laser, and without debulking and intravascular imaging, the final result would not be the same like in these patients when you discover that they need rota or IVL or else. So provisional stenting and side branch treatment. Side branch stenting is indicated only if the side branch is occluded, dissected, or has limited flow despite kissing balloon inflation. And the principles is to limit the number of stents, good apposition, and respect the anatomy and function. Those are different scenarios in distal left main disease. As you see, you can make it simple and you can make it very complex, but the key lessons is to keep it as simple as you can, plan your procedure according to the complexity, stepwise approach, intravascular guidance, and lesion preparation, as I mentioned. So let's talk for a while, for 2 minutes, about the techniques. Wiring the lesion. Why do we wire both lesions? Helps to keep the side branch open. In case of occlusion, the guide wire will marks the side branch, and the jailed wire can be used as a rescue procedure in some cases, extreme cases, to pass a low-profile balloon and dilate the side branch to regain some flow. And remember to remove carefully to avoid dissection or any other complication. Lesion preparation and dilatation is important for the main vessel. For the side branch, is not that important. Of course, for the main vessel, to allow planning, to know the exact size, the length, optimal stent expansion. For the side branch, we don't do routine pre-dilatation unless the side branch access is difficult, severe diffuse or calcified lesions, or the flow is compromised. Remember that debulking is now also part of the treatment if you are in need. Main branch stenting, of course, drug stents and the characteristics of stents with expansion ability that can give you bigger size if you need. Size of the main branch beyond the bifurcation, and both is very essential. As you see, of course, the size of the stent depends on the distal in the artery after the bifurcation. POT is very important to do. It's part of the bifurcation techniques to optimize the stent deployment apposition, restore the fractal geometry, reduces the possibility that the wire might cross behind the main branch stent, and facilitate access towards the side branch. It may facilitate crossing into a distal cell within the main stent. And then side branch opening. Provisional stenting allows side branch treatment alternatives at any procedural step. Distal main vessel stenting strut close to the carina to improve the distal side branch scaffolding and decrease the need for a second stent. Pullback techniques, sometimes we use it to allow better access to this distal part of the stent, and POT can facilitate the wire crossing. NC balloons are mandatory to get the exact size, and keep it open strategy is usually important. Side branch dilatation, as I mentioned, but remember the floating stents across the ostium may promote the development of, especially the CX, ostial fenestrated. It may cause restenosis, even in the absence of compromised side branch, and this is recommended to clear the struts from the ostium of the side branch. This is usually done if the procedure is OCT guided or by IVUS. Side branch stenting, in real world, almost 20% are needed in provisional stenting. I will not spend a lot of here, but the options here are either the tab or Keynote if the angle is allowing. Two stent recommendation in complex lesions, complex anatomy, and diffuse atherosclerosis. You need, in this case, very important two things: lesion preparation, and the procedure must be completed by kissing balloons and the final POT. So this is the algorithm. If simple provisional, it goes like this, and or if it is complex, whether the crush family, mini crush is one kissing balloon less than the dicky crush, and the Keynote or tab or T. There is two consensus by the European Bifurcation Club. Consensus 1 is implanting the first stent, and consensus 2 is to plant two stents, how to do, when to do. I will not go into details, but this is the provisional stenting, as you see, and there's some tips and tricks. I put it here, and maybe I can leave it with Professor Mahmoud, or implanting the second stent. Either it is T-stent technique. I'm sure other lectures had demonstrated how to make T-stenting, and they put T and tab together. There's some tips and tricks in that. Dicky Keynote or Dicky crush. Those are some details. In Dicky crush stenting techniques, the main pitfalls. First stent should be distal albuminal wiring of the crushed stent in side branch, and is for the second stent, albuminal rewiring favored by inadequate if the POT is inadequate. So make sure that the POT is not exceeding the side of the carina, otherwise it will make troubles with the second stents. These are the bench testing, and this is the final bifurcation stenting strategies mostly used in daily practice, whether professional, simple, or you go to two stent techniques, complex, whether the crush family or the TAP and T or Keynote. I think I have finished here. I will just show this case of distal left main, ostial LAD and ostial CX. ejection fraction is normal. So what we will do, whether provisional two-stent technique or take the IVUS and C or do cabbage. So IVUS guided before the pre-dilatation, as you see, to calculate the minimal lumen area, and of the LED ostium and the POC circumflex and proximal LED, and then you decide. So in this case, wiring and pre-dilatation, lesion preparation is very good. Wire both branches and pre-dilate. Stenting the main vessel and having a gelled wire in the side branch. And then post-dilatation on optimization by pot. And as you see, don't cross the carina. And then final check, the angio, IVUS. If this is okay, then the procedure is stopped, finished, good. But if there is a compromise of side branch, then you have to make distal rewiring of side branch, Qaisi balloon inflation and repot, as you see. And then crossover, provision stenting, and this is the final angio. And you recheck again with IVUS that you reach the luminar area that is adequate, and you are done. Comparing all the techniques, the D-crash has better data regarding the outcome. However, the procedure that you are familiar with is more important. The optimal upfront strategy is still provisional in the majority of cases. However, 20% may shift to two stents. All two-stent strategies have their pros and cons. Optimal use of one is performed and optimized. In all strategies, need good experience, stepwise approach, planning, lesion preparation, optimization. It is essential to have good experience in more than one two-stent strategy to be ready for Plan B. And thank you very much.
Thank you, Dr. Ahmed. Thank you, Dr. Ahmed. Panelists, Dr. Ayman, any questions? Dr. Qais?
At the end.
Okay, I have a question for you, Dr. Ahmed. Now, if you have a ostial LED lesion and you decide to treat that, the left main is okay, the ostial circ is okay, usually you go to the left main to position your stent and you do the pot. Now, the circ is okay after the intervention, just minimal, if anything. Would you go and open the cell struts to the circumflex? Because from experts, some of them suggest that you should do, others suggest that maybe it's harmful to do. Your opinion?
So this was a debate 3 years ago in the annual Bifurcation Club.
Yeah.
And the pros were towards just leave it if the lesion is not that significant.
It's not significant.
Yeah, the other theory is that maybe the flow may be compromised in struts, so let's open any of these struts. However, this is theoretical because you don't know which strut you will go again if something happens in the flow. So you better leave it, and according to this recommendation, if the provision is, you end with pot, very important. No need for Qaisi balloon now, only pot. And if the side branch is okay, you are finished. If there is some abnormal flow or plaque shift, then maybe you are guided with IVUS to see if it is compromised. Of course, if it's severely compromised with diminished flow, then you have to cross, and usually kissing balloon inflation and report again will solve the problem.
Well, I guess the theory is if you have an MI or an acute coronary syndrome related to a circ, whether proximal, mid, or distal circ, the access point is lost since this area is going to be probably endothelialized. So to me, I think I open the cell struts to the circumflex, but I'm not sure what do you do.
So what I do if the circumflex is, you know that the circumflex is the most notorious vessel for restenosis, especially the ostium circumflex. And what I do if I am obliged to treat this part, maybe I can use DCB for the circumflex if significantly affected. We don't now try to put stents in the circumflex unless it is mandatory to leave.
Oh no, that's not what I'm referring to. I'm referring to opening just the cell struts to the circumflex.
Yeah, the agreement now is just leave it. not
Leave it.
to open the struts.
Leave it. Okay.
Because the outcome had shown that it doesn't affect the
Thank
future.
you. Thank you. You have a question?
Thank you, sir. Very attractive, very informative lecture. But I want at the beginning to be answer your question. We are talking yesterday about your question and I answered the question, but I think you are not attend the session yesterday, right? You are here.
Who are you?
I'm Dr. Mohammed Matar from Iraq. So I'm going to ask you, answer your question because it's very interesting and there is a lot of the debate. What's update about your question, whether to open or not? Non-jeopardized osteal circ depend on the IVS result. Once when there is a metal across the osteal circ, and if then the opening is narrow, it's better to be opened by the final kissing balloon inflation. If you don't have IVAS in your cath lab, routinely should be go for the final kissing balloon inflation, just for better outcome in the future, to be get good access when there is any events in the mid or distal circ. This is the question and my answer.
Yeah, but the 16th consensus bifurcation club was clear, no need to do. Yes. Yeah, before that, yeah, our personal opinion, of course, matters.
This is definitely.
But I attended, it was between Ahmed Shiban and somebody from, yeah.
Yeah, so just a question for you, sir. Do you recommend NC balloon for the final kissing balloon inflation routinely, or you are going for semi-compliant? Is there any difference between the semi-compliant or NC balloon for the final kissing balloon inflation during kissing?
For final balloon, as I indicated also by the consensus, is NC balloons, not semi-compliant.
Is there no difference? Is there any difference or not between the NC versus semi-compliant?
Yeah, according to the studies they had done, one of the 10 recommendations, they called this 10 commands. One of them is NC balloon, not the semi-compliant. I don't know, of course, the background, if there's so many studies on that, but this is a consensus depending on the experience and the studies.
So the second question, if there is any
osteal... You have time for questions? Don't complain to me.
If we can leave the questions till the end to the discussion, because we're out of time.
Just rapid questions, okay? Because
we can't take any questions now. We have to move to the second speaker.
That's okay.
Thank you.
Okay.
So the second speaker is Dr. Hussam Suradi. He's going to be talking to us about bifurcation lesions. Thank you, Dr. Ahmed.
Good afternoon. It's great to be here again today. Fantastic talk by Dr. Magdy. He gave a fantastic talk that is a great segue for my talk. It's going to be a combination of a CTO and bifurcation case presentation. Our patient is a 53-year-old patient with exertional angina, no major past medical history. He had recently a nuclear stress test which showed ischemia in the LAD territory. He had the diagnostic angiogram done in outside hospital and was found to have a chronically occluded proximal LAD. So he was referred for PCI for that LAD. So we started by getting a dual access, a dual injection in the left coronary and the right coronary. And as you can see, the LAD is occluded just at the origin of the diagonal. You can see the proximal cap is blunt. However, it's well defined. There are good collaterals from the right, and the length of the lesion was roughly about 20-25 millimeter. So our plan was to initially attempt anti-grid wire escalation. If that doesn't work, we usually prefer going retrograde for the LAD. We try to avoid doing anti-grid dissection re-entry, just to avoid losing any diagonals that are important in the LAD territory. So we started with having our microcatheter. We tried several wires really to get into the LAD. However, the wire, as you can expect, kept off sliding towards the side branch. So we moved to use a venture catheter. Venture catheter is a steerable microcatheter. Another alternative that can potentially also be used as what we call a supercross microcatheter, which is an angulated microcatheter that helps us in directing the wire towards the cap. So with this and using a Gaia next to, we were able to puncture the proximal cap. However, the wire went into the subintimal space, and as you know, once this happens, it becomes a little bit challenging. We tried to reorient the wire and try to get into the true lumen. However, that failed. This is basically just a brief attempt to reorient the wire, which did not work. So we opted to convert to the retrograde approach. So we took a Corsair access, and with using a Xi'an black wire, we were able to get through the collateral all the way back into the LAD. And then actually after that, it was really very simple. We were lucky that the wire went true to true into the antegrade guide. And very important in these cases where we're involved with the left main is to make sure that the wire is in the true lumen before you start doing any kind of interventions. As you know, left main, there are important side branches, the circumflex and so on, that before it started ballooning and stenting, you have to make sure that the wire is in the true lumen. So the wire was externalized and an R350 wire was exchanged. And then we used a microcatheter over the R350 to direct a workhorse wire into the distal LED. This was followed by pre-dilatation. And now we took the retrograde gear. We only have the antegrade workhorse wire. And now we're ready for our bifurcation intervention. Initially, I was thinking of just going provisional, but the more I looked into it, as you can see, the diagonal is diseased. It extends at least 10 millimeter from the ostium. So the plan was changed into doing a two-stent approach. And two techniques that potentially can be considered here. One of them is decay crush, which I was comfortable with, and I prefer that in these cases. The other option that I think is reasonable is doing culotte here. One thing that I don't think it's very reasonable is doing tap in these cases due to the acute angle of the diagonal coming off the left main. This will leave a significant amount of strut into the main vessel. So going over the steps of decay crush, so we have two wires in the LED and the diagonal. We pre-dilated both of them, and then we advanced a stent into the diagonal, making sure that we have couple millimeter into the main vessel. And after the stent is deployed, the stent is crushed with the balloon in the LED. Then the stent is rewired and the first kissing balloon is performed. And this is followed by stenting of the main vessel, that is the LED, followed by pot, which Dr. Magdy mentioned the importance of it. It makes really rewiring into the side branch much easier. And you see here on the right panel the attempt to advance the wire into the side branch. This was a workhorse wire, nothing really challenging about it. And then we performed the second kissing balloon inflation, and we finished with a last pot. There was a small dissection just in the proximal LED, in the ostial LED, and we ended up putting another short stent in that territory. And this is our final result with TIMI 3 flow into the LED and really good flow into the diagonal. And of course, we finished with IVUS. Intracoronary imaging is very important in these cases, and we had really adequate MSA on IVUS, good expansion and apposition. And thank you.
Thank you very much, Dr. Hussam. Thank you. Any questions for Dr. Hussam? Leave it till the end. Okay. Thank you so much, Hussam.
Thank you.
Dr. Fadi Qaisi, interventional cardiologist from Jordan, the Unwanted in Bifurcation, PCI. Oh. This is the wanted. Bifurcation lesions. Yeah.
السلام عليكم جميعا. My name is Fadi Qaisi. I will present. I thought to present it this time a little bit different. So bear with me. I have no disclosures. So I want this to be a little bit more interactive. Bifurcations. So please, everybody, grab your phone if you don't mind. Go ahead. You can scan that or go to that website. Go ahead. I will give you a few seconds, a minute. Go ahead, scan it, because I will need your input. Once you scan it, you will go to that answer, and they're going to be testing, and that will be, I will test it myself. Perfect. So somebody start to vote. That's great. I will keep my eye on the clock. Nice, 9 people. 12 people. It's in the right upper corner. Beautiful. If you cannot join right now, you will join later on. With each question هيكون هذا اللوجو موجود. You can scan, you can participate. Okay, 32 people, great, amazing.
Just to clarify, awesome is better than unbelievably great, right?
Different. Yeah, okay. So, bifurcations has multiple, in each case we are going to present, there are multiple steps. There are medical versus revascularization, PCI versus bypass, to bifurcate, not to bifurcate, 2 stents, provisional, what type of bifurcation, technical execution. I will try to focus, هنركز على the 3 steps in bold, to bifurcate or not to bifurcate, 2 stents, provisional, and what type of bifurcation. We are going to leave the decision making and the technical execution. I know many people here, they are experts in technical executions. First case. 56-year-old gentleman, hypertensive smoker, presented with 3-day history of chest pain. He had elevated troponin, impression was non-STEMI. These are his angiograms. You can appreciate subtotal or total occlusions of the LED bifurcating with a diagonal. Left circ is appropriate. Please pay attention to the images. Unfortunately, when the voting comes, I will not be able to go back to the images. So this is another image for the left circ, diagonal. Sorry, LED diagonal. This is the RCA. So you saw the pictures? First vote, what would you do? Would you stent the LED only? Would you stent the LED and balloon the diagonal? Would you stent both using culotte? Or would you stent LED diagonal DK crush? Please go to your phones and start voting. I will wait for a few numbers to come.
What if I have another choice?
Yeah, sure.
Stent and DC.
And DCB, you said? That's good, but I will add that to the next session. All right, so we have 24 votes. Most people, they are saying stent the LED and diagonal, or okay, DK crush. All right, so many people, 35%, agree with me. I thought in this presentation, DK crush was the appropriate technique. The reason for that, because I have an LED culprit lesion. And once I obtain my wire in the LED, I do not want to lose my wire of the LED. And that's where the technique of the DK crush comes handy. In addition to that, I believe the LED, the diagonal was a big artery with diseased ostium that should not be left alone. So this is that's why I chose DK crush. This is the stent in the diagonal with a balloon parked in the LED, ready to crush. Obviously, we crushed the stent, we crossed back. This is our first case. And then this is the 2 overlapping stents in the LED. This is the second case. And this is the final result with both LED diagonal saved. It's very important to make sure that you have, as the doctors said, different techniques. You may need to change techniques in the middle of the case. Second case, 62-year-old lady, hypertension, diabetes, high cholesterol. She presented with non-STEMI. She was found to have 3 vessel disease. RCA-CTO, diffuse LED disease, total occlusion of the left circ, referred to bypass. She was turned down. She was brought back. I thought the left circ was the culprit lesion. And I will show you the images. These are her images. And so, by the way, for people, this is from Hamza, both cases. This is the second case or from Hamza. So this is the second case, and you can see I thought the left circ was the culprit because of the dye hanging, the clot formation. So this was the lesions. RCA was totally occluded. How would you treat the left circ? Stent the OM only. Stent the left circ only. Stent left circ and OM, open the left circ and re-evaluate. I will give you a few seconds to vote. Yeah, that's open the left circ, that's the balloon, and re-evaluate. So that's number 100%, 90%. So we have majority of people saying open the circ and re-evaluate. And that's exactly what I did. So this is ballooning. I have my wire in the OM, no ballooning. I have my wire in the left circ, and this is the pictures. We have the disease in the left circ. It was easy wiring, not a lot of resistance, not a CTO. So these are the images. I will let you have a second to look at it. Now what would you do? Stent the left circ only, stent left circ, balloon, OM, collot, DK crush, or stent left circ with the OM tab or mini crush. What would you do? She just come back from there. رجعونا إياها. All right, so it's 29% each or more voting coming. I will give you a few seconds more. So majority thought to OM, balloon the OM only. Second was collot and mini crush. Few people, they said DK crush. So what I did was I stented the OM first, and my plan was to do re-evaluate the OM. Once I stented the left circ, I thought the OM was a large artery, and I wanted to do collot for this case. So after I put my overlapping stents in the left circ, I went ahead and continued with the collot. I punted the stent in the OM. This is the kissing balloons, and that was my final result for the left circ OM using collot technique. I think I may squeeze one final case. So I have 73 years old gentleman, hypertension, diabetes, high cholesterol, multiple disease, coronary disease, AFib, heart failure, EF30, 35%, moderate MRTR, severe pulmonary hypertension, chronic kidney disease, creatinine 1.9. He had decompensated congestive heart failure, who is in maximal tolerated medical management. He was cath recently showing 3-vessel disease, including left main, and he was thought not to be a candidate for bypass surgery. This was his RCA showing significant instant restenosis. And this is his left main, left LAD, left circ disease. I apologize for the sub-engagement. It was difficult to engage. And you can tell this is from the intervention part because the decision-making has been done. So I will show you some pictures, and I have some still images at the end at the best frames I could present. This is his left main, LAD, left circ. Again, diffuse disease everywhere. So I stented his RCA. That was not tricky. Then I brought him back to work on the left main, LAD, left circ territories. This is the images. I will give you a second to look at them. And then get ready to vote. How would you do that? Mid-LAD, mid-left circ only, leave the left main. Left main LAD only, left main LAD stents and left circumflex balloon, left main LAD, left circumflex collot, left main LAD, left circumflex DK crush, the usual suspects. Please scan and vote. Okay, we have 17 people. All right, so 20 people, most people, they say stent the circ, stent the LAD, and left circ balloon. Actually, my plan was with the 29% DK crush. So I ballooned both of them. This is the after the ballooning, better images. You can see there's disease in the left circ, disease in the LAD, disease in the left main, and there is balloon pump, obviously, for support in this case. Insurance did not approve IVUS, unfortunately. So I started with ballooning. There was very difficult to deliver equipments. This is delivery of the left LED stent, the mid LED with anchoring balloon. And I tried to deliver long stent into the left circ with anchoring technique, but I could not advance the circ stent, the long one. You can see everything is pushed out, even with anchoring. So I substituted to 2 shorter stents. This is the first stent in the left circ. Then I put another shorter stent in the ostial left circ into the left main with the balloon in the LED parked, waiting to crush. So this is the crushing technique. And then this is the first kiss between both the arteries. This is the second long stent into the LED. And yes, there is left main dissection with all the manipulation. That's why I chose DK crush. I did not want to lose any of the wires of the LED during all case. Then this is the second kiss, and that was the final results for the left main LED. And the patient, luckily, left discharge next day. Balloon pump was, he's feeling well. I'm waiting to repeat his echocardiogram. I don't believe I have it.
No, we don't, Fadi. Thank you so much.
Thank you very much.
Thank you.
Appreciate it.
Okay. To Raed, this one is the unwanted in bifurcations. Sometimes the unwanted is the real scenario.
Okay, can we go to the first slide, please? Assalamu alaikum, Masa al-Khair. Thanks for sticking around with us. Hannah, thanks for introduction. Okay, so nothing to scan here. Don't use your iPhones. Okay. So we have a 61-year-old male patient, smoker, hypertensive, presented with non-ST elevation MI. He was cathed. One of the hospitals I work with, we have 3 colleagues. One of my colleagues took care of this patient. He had STT changes laterally with a positive troponin. You can appreciate the LED diagonal. So a decision was made for LED diagonal intervention. 2 wires. A stent was put in the diagonal, pre-dilated first with a balloon, then a stent. I'm going fast because we'll come to the point. Then a small balloon crush of the little protrusion, and then the LED stent was put, and these are the final results. So the patient, this is the final results, I guess. As you can appreciate, it was satisfactory to the team. Patient went home, but 3 days later, he presented with the lateral wall ST elevation MI. So I had the luck of cathing him at that time, and this is the cath. So there is a patent LED stent. The diagonal was gone. So immediately we went for the interventional part. We wired the LED. I had problem with wiring the diagonal. It was tough, really. But then we were able to wire it. We did balloon angioplasty of the diagonal, establishing some flow. And then we did a kissing balloon inflation for both LED and diagonal using non-compliant balloons. And then we ended with a pot of the proximal mid-LED. And these are the final results. So I guess the reason why I'm presenting this case is I'm not sure about the culture in the Middle East, but the question is really to kiss or not to kiss. So I'm not sure what we should. I know in Europe they love to kiss. Here, because of Corona, we don't kiss no more. So I need to admit that there is no better long-term results of final kissing inflation. However, there is a consensus, and الأساتذة اللي قبلي Dr. Ahmed Magdy was very clear on that. Most consensus, they said that if you are ending with a 2 stents, regardless if it is provisional or planned, you'd better finally kiss. However, if the end result with 1 stent and the side branch is left alone, unless there is a compromise in flow, don't touch that artery. And this is, again, for debate. And thank you very much.
Thank you, Dr. Raed. If you may stay, Dr. Raed. If you may stay, just a discussion for all cases. I have a question for you, Dr. Raed. Why do you think then this happened? Because there was no final kissing?
Yeah. And there's no pot.
And there is no pot.
Yes, so the carina was too much metal, stent over stent. I don't think the ostium was covered with metal.
Okay, thank you so much. Any questions, Dr. Raed or the speakers on this session?
You know, Dr.
Our
Hanna,
moderators, yes.
So, you know, coming to the point of when you're doing one single stent, do I need to cross and inflate?
Yes, thank you.
So I think, you know, going with the regular consensus, as Dr. Magdy said, and not doing anything makes better option probably, is because you're not disrupting the architecture of the stent, and also you're not doing injury to the ostium. So you don't really need to do a balloon if everything's okay. That would be a focus for, you know, instant thrombosis or instant restenosis. So unless you really have to, then you don't do it. But on the contrary, as you said, Dr. Raed, clearly, if you have 2 stents, then you have a lot of metal, and you have to change the architecture in a way that now you have good blood flow, good hemodynamics, so you have to finish with a kiss.
So I think this is a very educational session, and so the more we learn, the more we know that our knowledge is still lacking, and the more you do, the more you create complications. So now we understand that, for example, the circumflex ostium is notorious, and so don't put a stent there unless it is very necessary. The other thing is the side branch, no need to predilate, and no need to stent unless if it is so compromised, lesion is extensive. The pot is more important than the final kissing, as you had shown elegantly. And so the more you know, and the more you use the techniques that you are trained in, the better is. I can say that the Bifurcation Club, they don't advocate very much that he crush, although the guidelines of revascularization 2018 had mentioned this as one of the good techniques. They try to avoid too much manipulations unless it is necessary. And so I think this session was very important. I didn't have time to go into the details of each technique has its tips and tricks. But I'm happy to give my lecture to Professor Mahmoud, because I mentioned all the 10 commands by the 10 consensus of the Bifurcation Club in this part, and I hope it is useful for everyone.
Thank you.
Dr.
Fadi, تفضل.
Dr. Hanna, I have a question for you.
Yes.
My understanding, you said when you do ostial LED into the left main, you kind of routinely, most of the times, you open the stent side struts into the left circ, right? So 2 questions. Number 1, what's the final size balloon you use to the left circ? Is it 1:1 or just a small one to open the stent struts? Number 2, do you consider using a drug coating balloon for the LED, for the left circ because of the disruption of the endothelium, or use regular balloons?
To be honest with you, if it is a good size circ, I usually use a 3.0 NC just to open the struts proper, so that especially if there is mid-circ disease risks in the future for the circ. So it's not like a 1.0 or 2.0 balloon. I usually use a good size balloon to open the struts into the circ. But again, the data is very conflicting.
Yes.
Some supportive, some are not supportive. So that's why I think there isn't really a clear answer on this.
In fact, if I might
Doctor-
add, some of those studies showed harmful effects if you volunteer to do the provisional ballooning of the side branch.
Yeah.
Dr. Raed, very nice demonstrative case for the complication and the importance of further of the other steps of optimizing the bifurcation technique. My question about if we are assuming that the LED or the main branch is not so significant in this case, would you try just doing BCA with non-compliant balloon to the ostial diagonal? I know it is the culprit. And if there is no any dissection or significant residual lesion, to put a drug-coated balloon rather than putting a metal, we know the metal is the first offendant in this situation.
Yeah, I think it's a very valid point. I think the more we know about the drug-eluting balloons, the more we are going to use them. And as previous lectures in the last 24 hours, you can see extension of all what we were doing the drug-eluting balloon for in stent-free stenosis. Now it is for de novo lesions, and I assure you that if it is a branch like this diagonal and you can go safely with a drug-eluting balloon, leaving the LED safe without metal, I think it would be an excellent idea. I agree.
Okay.
Agreed, completely agree.
Thank you. We're finished with this session. Thank you so much. Coffee break, I guess, for 5
Can I
minutes.
just mention one thing, that we thank Sky and we thank Elizabeth Berkeley. Stand up, please. We thank Professor Mahmoud for giving this chance to Sky, and we are proud that the number of F-Sky from this region is increasing very much.
يلا الله يعطيكم العافية. عندنا 20 minutes